Hello, my name is Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota and the School of Medicine and Health Sciences. Today, I'd like to continue with our presentation for age-friendly healthcare and the element of what matters. This is part 2 of a 3-part series. So the goals for this presentation are to look at different strategies by which we can gather information on what matters. And then we want to look at health systems changes that can promote age-friendly healthcare. So this case study entails an 80-year-old female who has activities of daily living dependency with bathing. She is also a New York Heart Class 4 heart failure patient who comes to the emergency room after a fall and is found to have a comminuted femoral head fracture on the right side. In her What Matters documentation, it indicates, and the patient reaffirms this at the emergency room, that she wants to be as independent and pain-free as possible and still be able to see her grandchildren. So, with that in mind, what would be the most likely care plan aligned with her preferences? So the first one would be to admit her to the orthopedic service for hip replacement. B is to admit to the medical service for pain management. C, discharge the patient to home with palliative care. Or D, transfer the patient to a skilled nursing facility. So I'd like you to pick your answer here as I move on to the answer slide. Okay, so if you chose C, discharge to home with palliative care, that would be a reasonable answer given with what matters to the patient and her remaining life expectancy. So with New York Heart Class 4, she has less than a year of life expectancy, and she probably would not do well with surgery. And so it is an option with comminuted fractures to treat conservatively. And so that's why answer C would be the best answer. Answer B may be the second best answer, but then again, you've got the whole issue of iatrogenic disease that you might expose the patient to, and you might end up accelerating her demise as a result of that. So it's important in asking what matters. These are some of the things that primary care providers can do, as well as hospitalists and SNFists if you're working in a nursing home. Firstly, you want to check the electronic medical record for advanced directive documentation. If it doesn't exist, ask the patient if they've completed their advanced care documentation. And if the answer is yes, please bring it in. If it's no, then you can proceed to ask them some other questions and give them educational materials. So you're going to be asking all about the 4 M's, not only what matters, but mobility, mentation, and medications. And in the case of what matters, it's important to ask if they have any family members or friends that can help them if needed. That will tell you how much social isolation there is. You'd like to ask them to describe a typical day for themselves, and if they kind of give you a blank stare, you know that they probably don't have much of a healthcare plan in mind. And then finally identifying what the resources are that they have. Somebody can you speak to somebody or someone can speak for you rather if you're unconscious or unable to talk. And then list the things that you like to do in your life, any hobbies, family, travel, and so forth. So one of the things that you could use in clinical practice is what's called target practice. And what you do is you take these little sheets of paper, or they could be on magnetized printouts, and you have the patient apply different concepts here to the target, with the bullseye being the most important, and the outer rings, the red ring, being the least important. So it's important for the providers to consider the patient's prognosis. I often tell medical students that if you just simply look at the patient, if they look younger than their stated age, they're probably biologically younger than their chronologic age. how many times do we see patients that are in their 90s that look like they're in their 70s? And that's a pretty good metric, believe it or not. There's research that shows that your estimate of somebody's age based upon their appearance is a pretty good predictor of biologic age. You can also use e-prognosis or chronic disease calculators. These are both web-based applications to help you understand remaining life expectancy. Of course, you can use the Center for Disease Control lifespan tables, and those give you some averages with standard deviations of what the average life expectancy would be at a certain age group. It's also important to understand the functionality or the physical function of the older adult, and by addressing the activities of daily living. If there's a deficit there, you know that they're likely heading towards or are currently in a frail state, and those have prognostic ramifications for lifespan. And then also you can assess decisional making capacity, the ability to understand and to both understand and recall their activities related to advanced directives. So here's the CDC vital statistics. You can see that there's some differences between based upon race and ethnicity, but basically it lists how many years of remaining life expectancy you have at different ages. And of course, the older you are, by the time you turn 85, you're going to have a shorter duration of lifespan. And there are male and female differences. So there's about a half a year to a year difference between men and women as we get older. I mentioned e-prognosis. This is a web-based calculator that you can input your data. It's sponsored by the University of California, San Francisco, and it's a very good resource, e-prognosis. There are scales such as the Seattle Heart Failure Calculator. There's others for COPD and CKD. So I just alert you to these different calculators where you can again put in the data and come up with life expectancy. And you can see the graph up here. I mentioned measurement of the ADLs, so those involve assessments of whether the patient needs assistance with eating, bathing, dressing, transferring, toileting, and moving around, or just basically if they have an assistive device or not. So the importance of measuring functionality or functional assessment is that life expectancy will decline with increasing levels of frailty. So there's a healthy older adult at the age of 70 will have 18 to 20 years of remaining life expectancy. But as they become pre-fail, which maybe one or two items on the Freed frailty scale, where they say maybe they have fatigue or they've had weight loss, so they're in the pre-frail category, so they have half of the remaining life expectancy of a healthy older adult same age. And then if they're frankly frail by meeting 3 or more criteria of the Freed frailty index, then they have less than 3 years of life expectancy. And again, as a reminder, that's the they have already entered, their active life expectancy has ended, and they're now into the frailty state, heading towards a terminal event in the next 2 to 3 years. We, in our clinic, use gait speed. This really is a very good predictor of mortality, as well as future falls and future hospitalization. So you can see what the 5-year survival rate is for individuals that have less than 1 meter per second gait speed, and it declines substantially, so that half of the individuals who have a low gait speed of around 0.5 meters per second, half of those will be deceased within a 5-year period. Other things to consider about life expectancy: hypoalbuminemia is a very bad or very good predictor, I should say, of future mortality. patients leaving the hospital with an albumin of 3.0 or less have a greater than 50% mortality within 1 year. Unresolved delirium is another one of those metrics that are associated with increased mortality. Again, unresolved delirium leaving the hospital has 100% mortality within 1 year. Recidivism, so people that bounce back to the hospital, is another marker of mortality, as are frequent falls and, of course, increasing cognitive impairment with dementia. So, from a provider's point of view, it's well to consider where to start the conversation about what matters. And quite honestly, the annual wellness exam is perhaps the most advantageous setting for at least establishing the foundation for what matters. But some of the locations might not necessarily be the clinic booth, but rather in a conference room or the home setting. And we'll talk a little bit later on about how these kinds of arrangements can be made in a health systems transformation. So in dealing with the older adult, you want to start the conversation, and these are some guiding questions that you can use. What's important to you? What brings you joy? What do you worry about? And so forth. A lot of these are icebreaker questions. They don't always have to be done by the physician or the nurse practitioner, but they help if they do ask these types of questions. And then after you have those guiding questions, you have anchoring questions to hone in on their healthcare needs, and this just basically walks you through all of those points. So this is one structured way to ask what matters. And as you can see, it's something that you might not complete in one clinical encounter, and you might have a rolling opportunity to complete those questions over time. Excuse me, there we go. It's important to give the patient homework, and so I routinely give a copy of the PULSed and advanced care planning instructions. I'll also refer the patient to the Stanford Letter Project and also remind them to update their living will if they have, and if not, that they should probably get legal consults and update their living will. So completion of the PULSed is important, but quite honestly, the PULSed is the least important of the what matters. The PULSed is to be applied for when the patient is on their last stand, and it indicates their preferences for resuscitation. This is more for the ICU. This is more for the surgeons, and for the hospitalists. Quite honestly, it's not so much for the primary care providers, but we do want to establish these parameters so that the patient and, most importantly, the family and caregivers are in a position to express what the older adult's wishes might be. I mentioned the Stanford letter. This is, to me, really a well-done project for what matters. You can do an application, and you can put this on your phone. You can print it out and write it. And these documentations, these letters, can be entered into the electronic medical record. What healthcare systems have not done quite efficiently yet is to have little buttons that you can press on the electronic medical record that will pull this up and let you review it in a prompt fashion. It's also important to consider patient education. So if you've estimated life expectancy, and if the patient is willing to hear what your estimates are, sometimes you have to be careful with that. It can work both ways. I've told 92-year-olds that they're going to be living to 108, and I've told 70-year-olds that they're not going to make it to 80. And there's a wide difference in acceptance as to what the value of that is. With the younger person, with the shorter lifespan, potentially becoming depressed or apathetic of, well, what's the use of taking all these medicines then, as an example. So again, you have to kind of set the stage and understand what the patient's receptivity is for understanding remaining life expectancy. And you can put it in terms of active life expectancy rather than absolute. So how long do you want to be active for? And I asked a patient that once, and she looked at me, she says, a doctor's never asked me that kind of question before. And then she says, and you asked me about my goals. I said, I don't know what goals there are. So again, just engaging in the conversation can start the ball rolling. So to summarize session 2 here of what matters is that primary care providers and all providers need to continually assess what matters to the older patient. This is particularly true if their physical status or cognitive status changes. So there are tools for what matters, and they include the Stanford letter. We can use the life expectancy charts and calculators. It's important to do functional assessments, and so if somebody is impaired in bathing, grooming, transferring, feeding, these are very important considerations for their active and absolute life expectancy. And then finally, to be certain that the advanced care plans and the PULSE documentation occurs in the chart. These are actually one of the Medicare metrics for high-value care, that those are documented. And as I had mentioned earlier in the slide, healthcare systems typically are just under 50% at getting that kind of documentation posted. So I want to thank you for your attention here, and look forward to our continued conversation about what matters in the context and framework of age-friendly healthcare. Thank you.